Sharda Jain, madam.
एक
Who is
मिनट,
explored?
कविता कविता कविता,
Yes.
एक मिनट, जस्ट वेट। उनको वो लेट सही थी इन स्टार्ट द
Okay.
लाइव करेंगी ना वो।
Yes, ma'am. We
Okay.
are
Okay.
live
Okay.
now.
Sure. Sir. ठीक है, madam. Sorry.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcoming you all for today's webinar, Mission Neve webinar, and new PPH guideline, changing the way the world saves mothers. So it's my privilege to introduce the expert and program director of this webinar, Dr. Sharda Jain, ma'am. Ma'am is fondly known as Teacher of Teachers and Director of Life Care Center and Life Care IVF. I welcome you, ma'am. And it's my honor to introduce Dr. Archana Verma, ma'am. Ma'am is Vice President of Foxy in 2021 and Founder President of West UP ISOPAP chapter. I welcome you, ma'am, and I hand over the session to you.
So, Ashmarma, madam, will you speak something? Madam? Should I start
Yes.
right
Oh,
now?
just wait. Just wait. So,
Okay.
welcome.
Sure.
Welcome all. Welcome, dear friends and respected colleagues. Today we gather not just for a discussion for the PPH prevention, because it's our mission, and a mission to save mothers, a mission to prevent deaths due to postpartum hemorrhage. And from the days of silent tragedies to the era of evidence-based medicine, we have moved forward. And today we move forward together. And because I sincerely congratulate Dr. Kavita Barnwal to take up this mission. And we all know that she's a very reputed person, and one of the chairperson of Urogyne and Pelvic Floor Repair Committee, Foxy, and she's a big celebrity for us, and she has been she's associate professor in Lord Buddha Koshi Medical College, Saharsa, and recipient of Padma Bhushan Kamla Bai Hospital Award, and received Hira Award, and many awards to her name. And she has worked a lot and has organized many conferences, and I know that she is the one who was that did all the preparation for us to join Bhagalpur conference also, and Baba Devgad also. So your involvement, your commitment, and your continued support, we want Kavita for this also. And this actually Mission Neve was made by none other than Dr. Sharda Jain madam, and it because her vision was that each and every gynecologist should remember to know the same protocols, so that one nation, one protocol works for them, and that creates uniformity and minimum discrepancy, and learning is best by this thing. So we all know that these small steps, they matter a lot, and they create a very good effect and extraordinary results. So because when individual unite as a team, change becomes inevitable. And these guidelines are actually FIGO guidelines and WHO World Health Organization guidelines, which has been compiled very nicely by our veteran Dr. Sharda Jain madam, and she has made everybody to has asked everybody to present and to learn, because unless and until we teach, we don't become masters. That is her strategy, and we all know that Kavita will be telling us all about that roadmap to 2030 to curb this PPH hemorrhage to the best. And let us also reflect honestly, know our strength, and we must recognize our limitation also and all the challenges. So welcome, Dr. Kavita, and to give your talk on this very much needed topic. And we all want this key after this. Because Dr. Sharda Jain madam, if has joined, we would like to take her blessings before starting the scientific session. May I know Dr. Sharda Jain madam has joined? I think she has not joined as yet. So we welcome all the chairpersons, all the experts present here. So we would like to take their opinion after the Dr. Kavita's talk. So Dr. Kavita, welcome. It is now we all want you to speak out and do all the things. Thank you.
Thank you so much, madam. Thank you So thank you for giving me the opportunity to talk the new PPH guidelines, the way the world saves the mothers. So this is the program National Excellence in Early Emergency Vigilance, which is a mastermind of Dr. Sharda Jan Madam, who is expert and program director of this unique program to save the mothers. And Dr. Archana Verma Madam, who is national coordinator. Sia Sub Fox, she is vice president and she is founder president of Best BP ISOPOW, and all the experts who are here, Dr. Veena Acharya, Madam, Dr. Tarucha, and all the viewers and delegates. So, namaskar and good evening to all of you. So, every gynecologist is committed to save the mother because when a mother dies, the entire family, I think, collapse. So, just we have to see how can we prevent this preventable thing. So we all know PPH is the leading killer of the woman during birth, and following vaginal delivery is about 2 to 4%, while after cesarean section is 6%, and rural areas where the facilities are less, chances of maternal mortality is 12%. Overall maternal mortality due to PPH is around 27%. So this program has been made that every facility should be ready, equipped, and trained. Every birth should receive active management to third stage labor, especially uterotonic. And every woman should survive without preventable morbidity. So this program and this webinar is meant to end PPH death by 2030. This is global roadmap. So how can we achieve and how can we prevent this preventable thing that is PPH? So step 1 will be active management to third stage labor. Step 2 will be monitoring of the vitals, any complication that arise. Step 3, diagnosis of PPH, which is very important that early diagnosis should be done and to know the shock index monitoring, blood measuring traps. And step 4 will be emotive PPH bundle. Step 5 will be early referral. Once the woman is stabilized or even she is bleeding continuously, but we have to stabilize, we have to refer if the facility is not equipped properly. So to recognize, to act, and to escalate. These are the 3 aims of this mission, this webinar. So we have to be vigilant for early warning signs, and prompt treatment with PPH bundle can save our mothers and can reduce the morbidity also. So definition of PPH, you all are aware, when there is loss of blood. So if it is associated with the atonic uterus, if there is heavy blood loss, if large clots or constant trickle of blood is present, and change in vital signs, especially first and foremost tachycardia, more than 100 beats per minute, systolic blood pressure less than 100, diastolic less than 60, and shock index, which is calculated by systolic blood pressure divided by pulse rate. If it is more than 1, that means there is some sort of shock, and we have to be vigilant for that. Even the woman has no other concerning signs, then we have to see. Shock index is calculated by pulse rate divided by systolic blood pressure. I told wrong. So what to do? Prevention and early diagnosis of PPH is the key of this mission. We have to give an uterotonic, and blood measurement tools should be placed so that we can assess the amount of blood that the woman is losing, and placenta should be delivered with controlled contraction if it doesn't separate immediately. And we have to check the tone of the uterus because atonicity is one of the most important causes of PPH, and the 70% is responsible. And if it is soft, then we have to make it contracted by doing regular massaging. We have to check the bleeding, and monitoring should be done at every 15 minutes. And before that, we have to identify the risk factors which are present in that birth we can lead to PPH, like previous history of PPH, if there is twins or multiple pregnancy, if the labor is prolonged, if there is an history of hypertension or preeclampsia, any sort of infection, retained placental tissue, if the labor is prolonged and augmented, if she has given that she has augmented labor history, and the woman who is severely anemic, they are more prone to PPS. That we have to identify before giving birth of the baby. So first and foremost is giving a uterotonic. This should be done immediately after birth within 1 minute. Oxytocin is still preferred. Tenunis, IM or IV. IV is preferred if already IV line is there. It should be diluted and given slowly over 1 to 2 minutes to prevent hypertension. And this molecule should be refrigerated between 2 to 8 degrees centigrade. Another uterotonic, that is oxytocin receptor sensitive, carbetocin. It can be normal refrigerated, or it can be heat stable. Both has similar dose, 100 microgram, IM or IV. If IV, it should be given slowly over 1 minute. And nowadays, heat stable carbetocin is being available where refrigeration is not needed. Only protection should be done from the light. And another uterotonic that is easily available is prostaglandin, even analog, that is bisoprostol, which is given in the dose of 600 microgram orally, or it can be given sublingually or per rectum also. So these are the uterotonics which should be ready when a woman is going to any facility for birth. Second important thing is to measure the blood loss accurately, and this is mandatory thing. For that, we need to keep the drafts with calibrated funnel, trays with the calibrated lines, and any other innovation that has been made to just measure the amount of blood that the woman is losing. If any blood loss has been outside this funnel, this should be served and should be kept into the tool so that we can measure exactly and the amount of blood in the tool and what is the flow. Dangerous bleeding can be sometimes slow, sometimes steady stream, or sometimes a large gus when there is any spurt or any arterial like cervical artery is injured. For early diagnosis, objective management of blood loss is the key. This is most important to know whether she is going to have PPH or what. So after giving intertonic, we have to start measuring the blood loss accurately with the calibrated tools. Then we should wait for 1 to 3 minutes to cut the cord. If the woman is bleeding profusely or if the baby is not doing well or not breathing well, then we can cut it before 3 minutes also. Otherwise, after signs of placental separation, when there is gus of bleeding or lengthening of the cord, this control contraction should be done only during contractions so that placenta easily gets separated and comes out. We should not try hard on the cord because it will get evulsed, and if evulsion occurs, more difficulty occurs in removing the placenta. If any resistance is felt, then we should avoid because there can be chances of tearing of the cord as well as inversion of the uterus. So that we have to see, and a controlled contraction should be done only by the specialist or expert midwives. Then we have to check the tone of the uterus. It still appears to be soft, then we should massage it. Uterus should be firm at the level of midline or at the level or just below the umbilicus. If the fundus of the uterus rises above the umbilicus, or if it is on one side and becomes soft again, then there are chances the bladder may be full or the uterus is full of clots. For that, we need frequent urination or sometimes catheterization also, and clots, if present, should be removed, if preferably by suction apparatus. And after removing the clots, we can do the massaging of the uterus, and bladder should also be emptied so that uterus gets tonicity and it contracts well. We have to remember that always IV lines should be inserted in any woman who is going to give birth, and uterotonic should be prepared before birth. Oxytocin and misoprostol, these are mostly used for the prevention as well as treatment of the PPH, while carbetocin is given only for prevention, and so it should be kept ready in women who are at high risk of PPH. It's not routinely given in every case, but those who are at risk, this should be given. And many times, combination of oxytocin 10 is either IM or IV or misoprostol 400 to 600 microgram per orally can be given. Tranexamic acid, injectable prostaglandins, ergometrin, or in combination with oxytocin, many days, ergometrin and oxytocin are available in many centers. This should not be used for prevention. They should be used only if there is PPS and it's not being controlled by a routine uterotonic, then these molecules should be tried. We have to remember that soft uterus, that is atonicity, is the #1 cause of PPS. A hard uterus feels just like cricket ball or like forehead, while soft uterus feels like the tip of the nose or that has doughy feel. So we have to feel the uterus, whether it is contracted or not. Uterine tone can change quickly. A bladder, when remains full, then it prevents uterine contraction, and it is one of the most common cause of relaxed uterus. So that's why if the bladder is full, we have to make it empty. If placenta is not out and there is heavy bleeding, then we have to start PPH treatment bundle immediately, and then we should move to removal of the placenta. So whenever there is bleeding, we have to start treatment, whether placenta is separated or not, it doesn't matter, but PPH bundle should be started immediately. Then we have to check for the bleeding. If there are warning signs, then even 300 ml blood loss should make us alert, like a tonic uterus, heavy blood flow, large clots, a constant trickle of the blood. These are the warning signs which make us alert that there is chances of PPS. And even there is no warning sign, but blood loss is more than 500 ml, then uh, then it should be uh, then we should be alert so that we can start treatment. And clinical judgment is also important. The rate of blood loss, presence of risk factors. So these all things we have to see, and we should be alert. Monitoring should be regularly at 15 minutes after birth. If placenta is not delivered, where we have to see the pulse rate, blood pressure, and shock index. And then we have to see the tone of the uterus, volume of the blood loss, and flow of the blood that is coming into the calibrated drifts. Again, blood pressure pulse should be taken. If pulse is more than 100, systolic blood pressure less than 100, diastolic is less than 60, and shock index is more than 1, then it warns us that she needs further treatment, and therefore we have to monitor vigorously at every 15 minutes for first hours, and then at every 30 minutes for next 2 hours. So if the placenta is not out after 15 minutes, we have to check the bladder. If it is full, it should be emptied, either catheterization, or the patient can be asked to urinate. And then we have to repeat control contraction. If placenta doesn't come out after 30 minutes, or there are chances of retained pregnancy of the placenta, then it should be removed manually. Placenta usually delivers within 15 minutes when tonics is given, just within 1 minute of the birth. But if it takes longer, then we have to move and we have to take the action accordingly. If even placenta doesn't come, then we should call for the help, because there are chances of adherent placenta and it may require laparotomy and possibly total hysterectomy. After placenta is removed, we have to check it for the completeness, whether any cotyledon is missing, any membranes are missing, that we have to see if any missing lobes are there. But if uterus is firm, placenta is complete, and still there is bleeding, then we have to check for the tears. There can be cervical tears, cervical tears, vaginal tears, and it can lead to bleeding also, and that can cause PPS. Simultaneously, we have to assess the baby also, his color, temperature, breathing, condition of the cord, that should be checked. And all these things should be recorded on the newborn chart. And baby should be touched to the mother, and breastfeeding should be encouraged. And women should also be assessed for uterine tone, blood loss, flow, pulse, and blood pressure. And all these things should be recorded in the postpartum monitoring form. We have to involve the woman to prevent PPS. So we have to teach them how to check, how to massage her uterus herself. She should be encouraged for frequent urination, and if she notices bleeding, she should speak up. After 1 hour, if the patient is stable and there is no bleeding, then we can remove the blood loss measurement tool, and she should be moved to postpartum ward. Women and babies should stay together in the facility, and breastfeeding must be encouraged for 24 hours after a normal birth. So in any case of PPS, start treatment bundle immediately. So for early diagnosis, we have to be alert. We have to identify the high risk factors and should assess tone, flow, amount of blood in the measurement tool, pulse, blood pressure, shock index. And these are the warning signs when their uterus is not contracting, large amount of class and heavy blood loss, and the change in vital signs. So this is summary when we have to give it a tonic, either oxytocin, tenunis, or carbetocin, or misoprostol within 1 minute. We have to start the measuring blood loss, cut the cord within 1 to 3 minutes. If the placenta is not separated, then we can go for controlled contraction and be alert for PPH. With 300 ml along with warning sign, with 500 ml without warning sign, and with clinical judgment. So early diagnosis, which is the first step of treatment. Once PPH is diagnosed, we should call for help, because we have only some time. I think first hour is most important time when we can control the PPH and we can save the mothers. So this is the preventable thing that can be prevented. So just we have to identify risk factors like previous PPH with twins or multiple pregnancy, prolonged or augmented labor, preeclampsia or hypertension, any sort of infection, retained placenta, and severe anemia. And uterotonic should be given. Measuring blood loss should be done with calibrated reps, and controlled contractions should also always be done by trained staff, or if there is any resistance, it should be stopped. Golden rules are IV lines should be inserted, uterotonic should be ready. We have to identify the uterus, whether it is a soft or it is contracted. If it is atonic, then we have to massage it. If necessary, we can give tranexamic acid, oxytocin, IV fluid. The cause should be verified and treatment should be escalated. So these are the red flag signs that we have to find out. We have to stabilize the woman, temporize the woman, and then we have to, if necessary, if the facility has not so much facilities, then we can refer it. So prevention is the backbone along with the early recognition, which can save the lives of the mothers. So when PPH is diagnosed, what can do? Call for help. This is most important thing. In fact, all the staff, all the persons should be on alert that we need emergency treatment. So emergency equipment, medication should be ready. We have to assess the shock, communicate with the woman, the health team, the established rules, and start the treatment bundle, which is most important part of the maintaining PPH, controlling PPH. So this treatment bundle is a set of interventions that when given together improves outcomes. This mnemonic motive must be remembered, which includes massage the uterus, give the oxytocin, give tranexamic acid, give IV fluids, examine to find the cause of bleeding, and after that, we all need to escalate it. We have to improve it or do fast. Massaging of the uterus is one of the most important thing to cause uterus gain tonicity. For that, once the bladder clots are removed, we have to assess for the distended bladder, and then we will massage it. After massaging, we will give oxytocin, which can be oxytocin or misoprostol, or even both can be given 10 minutes IM or IV in 100 to 500 ml crystalloid fluid. It should not be given very fast to prevent hypertension. It can be given even in bolus in 2 minutes time. And sometimes a woman comes in hurry and IV line is not inserted, then we can give IM also along with misoprostol 800 micro. Tranexamic acid needs to be given over 10 minutes. 1 gram dose is there. Faster administration can cause hypertension. Tranexamic acid and oxytocin can be given in same line. Suppose there is only one IV line, then we can give it simultaneously, but not in the same bag. Tranexamic acid should not be given if birth has occurred more than 3 hours back, and if there is any contraindication of tranexamic acid or the woman is hypersensitive to tranexamic acid, if there is any known thromboembolic event, history of renal failure, or history of convulsion. In these conditions, we should not give tranexamic acid. IV lines should be inserted earlier, but still it's not being started. 18 gauge cannula should be inserted, or even largest if available. Blood should be collected for lab testing, like hemoglobin cross-matching and clotting studies. And crystalloid fluid like RL or ringos lactate or normal saline should be started. Oxytocin should be given in the fluid. If clinically indicated, if the patient is having more PPH, we can go for second IV line also with the crystalloid fluid. Then we have to examine to find the cause. Atonicity is the most common cause, like including causing 70% of PPH, but still there can be retained tissues, placental tissue that accounts for 20%. There can be tear or trauma that accounts for 10%. And in about 1% cases, there can be thromboembolic disorders that can lead to PPH. We have to examine. We have seen the tone of the uterus. If it is atonic, we have to massage. If it is contracted, well contracted, then we move for the seeing the placental tissue, whether there is any missing cotyledons, lobes, fragments, or membrane. If placenta is not coming properly and seems to be adherent, then we should suspect a creta, and in this case, surgery is required. Then we have to check for the trauma, like perineal, vaginal, or cervical, or tears. If there are, it should be recognized, should be seen in good light, and it should be repaired immediately. Sometimes during removal of the placenta, if properly controlled contraction is not done, uterus gets inverted. We have to replace it immediately because it can further lead to PPH as well as shock, and then other protocols should be followed. Sometimes, if we suspect there may be rupture of the uterus, especially in multipara, if there is any history of trauma to the uterus earlier, like myomectomy or previous cesarean, in such condition, we seek advanced care. And we have to rule out thromboembolic disorders also. For that, we need to collect blood for hemoglobin, typing, cross-matching, prothrombin time, partial thromboplastin time, platelets, fibrinogen, and coagulopathy. So all these things should be measured simultaneously to know what is the exact cause of the PPH. And last is the motive in this bundle, that is escalate. Escalate care. If bleeding is heavy while giving the bundle or continuous even after bundle is complete or more than 1000 ml at any time, then we have to escalate the treatment. If the woman has extensive trauma or has uterine version or hypertensive or unresponsive, then we have to escalate. And if she is unable to identify or manage the cause, if there is we are not able to diagnose what is the cause of PPH and patient is going into shock, then we have to escalate. And when women's life is in danger, we have to act fast. We have to shout for help, we have to call for help, and we have to start all the treatment. We have to escalate the treatment. So call for help, call senior, continuous monitoring should be ready, anesthesiologist should be called, it should be communicated, and all the other treatment like massaging, catheterization of the bladder, clots from the cervix, uterus should be removed, preferably with suction machine. If uterus is not firm, we have to massage again in a way and similar to manual removal of placenta. If needed, then we can arrange for transfer or even surgery required, then we have to move for the surgical process also. If there is not such facility, we can apply NSC because NSC is one of the things that can at least give some time. So if the woman appears to be in shock or risk, there are chances of risk of shock, then we have to apply NSC. Blood transfusion should be ready and antibiotics, if not given till now, we have to start antibiotics also. Second IV line should be placed. If till now only one line is there, and additional protonics should be started, like oxytocin 20 units in 1 liter of crystallite, like Ringer's selected IV, and it should be infused at the rate of 40 drops per minute over 4 hours. But more than 3 liters IV fluid should not be given, and maximum amount of oxytocin that is can be given in 24 hours is only 60 units. Sometimes ergometrin or ergometrin oxytocin combination are available that can also be given. Ergometrin should be given in the dose of 200 microgram IM or IV in 15 minutes if repeated only after 4 hours, and maximum 5 doses can be given in 24 hours. If we suspect there is written placenta tissue or if there is any history of hypertension, then we have not to give the ergometrin or oxytocin this combination. Misoprostol is safer one, and it can be given at 800 micrograms sublingually or per rectum. Tranexamic acid second dose can be given 1 gram IV over 10 minutes. If the bleeding continues more than 30 minutes after first dose, or if it restarts within 24 hours after first dose of tranexamic acid, it should be repeated. And we have to assess and record at every 15 minutes or more often until patient gets stable. We have to check the tone of the uterus. We have to assess the blood loss. We have to see the flow of blood that is coming out and first blood pressure along with the shock index. Shock assessment is very important because it will tell us how much time you have and how fast we can do. For that, we need ABC, airways, breathing, circulation, all should be checked. It should be managed accordingly. And if needed, transfer should be arranged or surgery should be started. NSC must be applied if there is chances of shock or risk of shock, and blood transfusion should be kept ready. Thereafter, we need for advance. Even still, all this has been completed, PPH bundle has been completed, but still there are chances of PPH or there is chances of shock, then we need advanced intervention. For that, we have to assign tasks, insert a second IV line, give extra doses of medication. Again, we have to look for the tears, call the seniors. Sometimes tear remains at a higher level and we miss it. So we have to find out whether there is any tear in the upper part of the vaginal area. And if there is any missing placenta, we have to remove it. Clots and tissue present should be removed and NSG should be applied. There can be more than one cause of bleeding also. Where also we need advanced intervention. And if we suspect uterine rupture, especially in cases of prolonged augmented labor or prior cesarean section, then we have to do advanced intervention. Sometimes deep cervical, deep vaginal laceration are there, then we need advanced intervention. So what is advanced intervention? We have to start blood transfusion, that should be safe. In severe or ongoing PPS, there is and when there is clinical need after cross matching, and we have to arrange more blood. If the woman is severely anemic, like hemoglobin less than 7 gram per DL, or she looks anemic clinically, sometimes hemoglobin doesn't uh, come out so low as she looks. So in that case, also blood transfusion should be started immediately, and we have to recheck and vaginal cervical laceration, and if they are present, then it should be repaired immediately. And bimanual and aortic compression, they have very good role in preventing PPH and even treating PPH. In treatment of PPH mainly, and if necessary, uterine balloon tamponade should be inserted and NSGs should be applied. So how to do bimanual compression? This is for temporary control of bleeding, where when uterine atony allows hemorrhage to flow into the uterus, we can massage it gently from the fundus, as well as we can do bimanual compression, where one hand is inserted in the anterior vaginal fornix and other hand behind the uterine fundus. And we have to squeeze the uterus between the hands for at least 5 minutes. After 5 minutes, the hand should be removed slowly, and we have to check whether again bleeding occurs or not. If bleeding again starts, then we can resume compression. If there is no bleeding, then we can continue IV line only. Compression of abdominal aorta is another important step in treatment of the PPS, where we have to apply downward pressure with closed fist over the abdominal aorta through the abdominal valve that lies just above the umbilicus, slightly to the patient's left. And we have to palpate the femoral pulse with the other hand to see whether this compression of the aorta is complete or not. If femoral pulse is palpable, that means the compression is inadequate. And if the pulse is not palpable, then that means that compression of the abdominal aorta is adequate. This compression should be maintained until the bleeding is controlled or until the patient reaches the operation theater. So we have to shift the patient with compression of the abdominal aorta so that we can stop some amount of bleeding, which is bleeding profusely. Even uterine balloon tamponade can be inserted, but before that we need to compress the aorta with one hand, and before inserting uterine balloon tamponade, we have to check and remove any retained tissues or clots that are present. Again, we have to check for the tears. Sometimes deep tears are missed. That should be ensured that they are properly repaired and there is no further any injury to the cervix or vaginal laceration. Bladder must be emptied, and then uterine balloon tamponade can be inserted in the uterus. And then we have to monitor blood loss. If still there is bleeding, even after 15 minutes, then we need surgical help. Deep vaginal tear or cervical tear must be identified and repaired. Sometimes there is slow trickle of the blood that comes, is mostly venous, but it bleeds and it can cause the woman to go into the shock. And sometimes there is any spotter and that bleeds heavily or profusely. Here also we have to identify and we have to repair it. Venous oozing can be controlled to a certain extent with pressure and with packing also. And even these repair does not stop bleeding, then we need advanced care or where surgery may also be required. NSC is a lower body compression device made of stress neoprene which closes tightly with the velcro in segments for the ankles, calves, thighs, pelvis, abdomen, and is applied rapidly starting at the ankles. It forces blood to the heart, lungs, and brain to prevent shock or stabilize the woman in shock. This is the diagram of NSC garment that is available 3 pairs and 1 unpaired, and that should be applied fast so that our vital organs can be saved. If all these methods are done, then we have to address the causes. We need to do surgical intervention, like uterine compression sutures can be of some help when the uterus is not contracting properly, and then we should move for stepwise devascularization. When uterine artery ligation is done, internal artery ligation is done, and if the facility is not aware of all these things, then we need to move for peripartum hysterectomy. That should be emergency because this is decision making, and many times the woman can be saved with this peripartum hysterectomy also only. If the patient is hemodynamically unstable, then We will do subtotal hysterectomy, but if it is stable, then we can go for critical surgery also and total hysterectomy. We have to monitor closely until the woman becomes stable. For that, we need to give oxytocin 10 units at 500 ml as a maintenance drip. We have to ask the women to take more and more fluids, she should be hydrated. And if the bladder is empty, then we can remove the catheter also. If oxygen demand is decreases, the patient is getting better, then we can remove the oxygen or at least decrease the oxygen flow. And we will support breastfeeding, because breastfeeding itself will prevent PPS. It will cause release of oxytocin, and that will cause tonicity of the uterus. And all the lab tests should be repeated, full blood count, hemoglobin, as per protocol. And women should be then encouraged to do some physical activity. Gradually, she can move. So we have to remember that administer all intervention, even the woman improves after only 1 or 2. The order doesn't matter. PPS bundles are merely to control and manage atonic PPS. The golden hour is supposed to be first 60 minutes, which is most critical following diagnosis. Use all modalities of PPS treatment in first 60 minutes, because this is the golden hour where when we are alert, we are active, we are vigilant, we are escalating the treatment, we can save our mother. So 20 minutes of medical management, 20 minutes save the uterus technique, and 20 minutes final surgical procedure that can be hysterectomy also can save our mother. And this is our motto. This is the motto of FIGO and the John Global Map 2030. So just to summarize, once diagnosed, PPS call for help, emergency equipment and medication should be ready, shock should be assessed, communicate with the women health team and establish the roles, start the treatment bundle, which is the motive, massage, oxytocin, tranexamic acid, IV fluid, examination and address the cause, escalate the care. When the bleeding is heavy, and while giving bundle or continuous, even if the bundle is complete, more than 1000 ml blood loss at any time. If the woman has extensive trauma or has uterine inversion or hypertensive or unresponsive, or sometimes we are unable to identify and manage the cause, then we have to escalate the treatment. What is the escalation treatment? Like call for help, call senior, call anesthesiologist, continue monitoring, communicate massage. Bladder must be emptied by catheterization. Remove the cloth from the cervix, uterus. Second IV line should be started. Additional introtonic like oxytocin, ergometrin, misoprostol should be given. Injectable tranexamic acid should be repeated. And still patient is bleeding, then we need advanced intervention like blood transfusion should be started. Recheck and repair the vaginal cervical laceration that might have been missed earlier by manual uterine compression to make the uterus contract, balloon tamponade, aortic compression, along with the anesthesia garment. And we have to assist for the shock and manage accordingly. If needed, we have to arrange transfer. We have to stabilize the men. Simultaneously, we have to arrange the transfer also. When all these methods fail, address the causes, do surgical intervention that can be like uterine compression sutures, step by devascularization, internal iliac artery, and if all these are not being done or not available, then emergency peripartum hysterectomy, which is the decision-making clue, and along with the timely reference. That is most important thing to save our mother. So the same thing, how we can go, massaging, oxytocin, tranexamic acid, IV fluid. We have to manage the shock, and we have to escalate the treatment, and we have all these methods have been done, but still she is bleeding. Then we have only option, that is surgery, and we should not think for that. We should move immediately, and we should proceed for the hysterectomy also. Referral and transfer is very important. When the patient is bleeding continuously and there is need for blood transfusion, need for surgical intervention, atony not controlled by heterotonic uterine massage. When there is suspected trauma like genital laceration, when there is massive hemorrhage with signs of shock, and there is failure of less invasive temporizing measures like uterine balloon tamponade, or inability to place and maintain them safely, then referral transfer is better option, and we have to refer it. We should not delay in referring the patient. We have to follow the stabilized, temporized transfer principle. So before shifting, we have to stabilize the woman. 2 wide bore IV lines should be started along crystallized introtonic tranexamic acid. Uterine massage should be done simultaneously. Bleeding should be controlled by bimanual compression, aortic compression, along with the tamponade. And referral note must include what are the vitals when patient was referred, and what was the estimated blood loss, what are the drugs given, what intervention has been done till now, when Avilan started, that should be mentioned in referral note. And we have to inform the receiving center where the patient is going, but to everything. Blood bank should be ready, make ready, so that she doesn't get delay in receiving the blood. And transfer should be done with skilled staff along with the continuous monitoring. So this 5G referral system is very important for preventing PPH or treatment of PPH. This is GPS tracking. It's basically for treatment of PPH. Once the PPH has been stabilized, we have to maintain these 5Gs. That is GPS tracking, real-time ambulance position is shortest route, geotag facility should be there. We have to find the nearest center with OBG blood bank capability, and guideline-based decision tool. The app prompts to ensure stabilization before referral. Gigabit connectivity, where live video consult can be made between PSC or community health center, and especially during resuscitation. And golden hour dashboard allows tertiary center while patient is in the transit. So this 5G should be followed in every case of PPS, so that we can provide appropriate treatment and the best treatment to the woman at time. Documentation and debriefing are another important thing in PPS. So what was the time of onset of PPH? What was the sequence of events? What is the time and sequence of administration of all the pharmacological agents like tranexamic acid, blood products, and what was the time of surgical intervention? And what was the condition of the mother throughout? That should be mentioned minute by minute, so that we can know what was the region and what was the cause where we were failed and we are not giving proper treatment. So that should be maintained. Documentation should be done in every PPS case. Ensure the women's record complete. For that we need hemoglobin CBC count. A normal vital signs should be ensured, urine output, mental status. If there is any dizziness with walking, then we have to see whether she is in proper condition or not. If she has no dizziness with walking, then she can care for herself and her baby. And we have to also rule out any sort of infection. If there are chances of infection, we have to start antibiotics or even continue the antibiotics as per protocol. And routine postpartum care, including family planning, should be provided. This is most important time when she has faced so many things that she will adopt any sort of family planning what is required for her. And then we have to counsel for the risk of PPH in future also and its importance. And then she will be asked for follow-up at 48 hours, 10 days, and 6 weeks. That is at the period. Prevention is the backbone in any case of PPS. We have to identify high-risk women. That is most important thing. Antenatal optimization should be done, where we have to assess, address the anemia, blood pressure should be monitored, and birth preparedness should be met. Whether she is a case of high-risk, she should be delivered in better centers, tertiary centers, and we have to diagnose early. Earlier diagnosis saves many lives, and now new threshold is 300 ml. Earlier it was 500 ml, but now new threshold is 300 ml. You have to recognize early warning signs, and objective management blood loss is very important, so that we can know exactly what amount of blood loss she has done. For that, we need gravimetric and calibrated refs that should be applied in every birth, and we have to check the pulse, blood pressure, shock index, because if it is more than 1, that means patient is getting severe shock. And this motive WHO bundle care must be used in every case, and any step is not missed that we have to ensure. Golden hour concept is very important, where first 60 minutes should be very vigilant and very alert. Every person should be alert in this golden hour, and every protocol should be followed of motive, so that we can apply all the things, medical, surgical, everything, so that we can save the mother. And we have to also assess the 4 T's, that is trauma, tissue, tonicity, and thromboembolic disorders. Rapid escalation and decision-making pathways should be followed, and surgical readiness should be there. Sometimes we are reluctant that, okay, seeds primary, seeds needs or uterus to be saved, that we have not to think at that time. We should act fast if bleeding persists because this will save her life. Early action improves survival, so we have to act earlier. Team communication and stimulation drills should be there, and respectful maternity care during emergencies. We need everyone needs this respectful maternity care, and every facility should be equipped with these facilities and also to tackle the emergencies. So this FIGO WHO guidelines we have to follow. Our motto is to save all women who are dying of the PPS or who are at risk of PPS or who are having chances of morbidity due to PPS. And our strategy should be to prevent PPS death due to PPS by 2030. Once again, thank you so much, Program Director Sharda Jain Madam and Archana Verma Madam, National Coordinator, for giving me opportunity to talk in front of you. Thank you, madam. Thank you
Thank
so
you.
much for patient hearing.
Thank you, Kavita ji. Thank you. I must say, before
Thank you, Tarucha madam.
so thank you for
Thank you
accepting
so
the
much.
invitation,
बहुत अच्छा बोला.
Kavita ji. And it was truly an awesome presentation by you. And you strongly emphasize the importance of AMTSL, timely diagnosis, and with 4T. But if we remember 4T and the three are from uterus only. So we will be more focused. And then a timely call for help and timely referrals, that too in a special protocol, whatever you can do. If we apply NASG, it will definitely buy so much of time that there will be less worries, and timely escalation. And very important, these are very important messages for all of us. And Saidi, please present that certificate to Kavita, which has been made by our team, Dr. Sharda, Dr. Taru, and other people. Yes,
Thank you
please
so much,
accept.
madam.
Please accept, Dr. Kavita. This is small. You don't need this, but as such, because we are giving to all champions, and we are really honored to have you today. And before we invite other, like Dr. Taru, you say a few words.
Dr. Kavita, it was very nice deliberation, and all the topics are clearly narrated, and very just as if you yourself is doing everything, and you are telling us this has to be done. And all the protocols are very well set, and the sequence wise. Thank you so much that you have done this, and we will like this much should carry on your side also.
Yes, madam.
Do for
Sure.
that.
Yeah, we will do in the college also. Okay. Thank you so much. It should be, I think it should be known by every person, every gynecologist, even PG students, even any government doctor who is tackling this situation. They should know at least.
You promote that.
Yeah, madam. Yeah, yesterday my husband is in government job. He's deputy superintendent. He narrated everything in front of him. I told him that I will speak in your hospital also. Then he told, okay, you can do. So yes, madam.
Nice,
Will
very
do.
nice.
Yeah.
And one thing I wanted to tell you, that without saying people can support for this cause, without saying, without asking, like those charts you saw, na, that PPH posters that were made by Taru on her own. We didn't ask her, but it is her basically passion to do things in a nice way. And she is with us, and she made with the guidance of Dr. Sharda, and of course, but they were especially made by Dr. Taru Chaya, only and only by her.
Thank you, madam. Thank you,
Thank you so
Chaya,
much.
madam.
Thank you so
It
much,
was
Rajna,
awesome.
madam.
Yeah, thank you so much. Thank you for giving me and making a part of this journey. So
Yes,
if I will be helpful, I will like to do more and more, and I will must it propagate to every person so that everyone should know how can we save our
Yeah.
earth.
Dr. Sharda Jain को देखो मैडम किधर है, अगर she can join and she can give blessing. कविता मतलब इसको पढ़ने के बाद लगा ना कि कुछ complete सा है, हर चीज इसमें और मतलब like it takes at least 2 hours to
Yes, madam.
complete finish it nicely, because एक लाइन भी ऐसी नहीं है जिसे आप कट कर सको, और एक लाइन भी ऐसी नहीं है जिसे आप ये सोचो कि इसका
Add कर सको. Exactly, एकदम बहुत ही अच्छा बना हुआ है,
इसमें
बहुत बढ़िया
सारे कंसेप्ट आपको, जैसे हाई रिस्क है, हाई रिस्क में प्रिवेंशन के लिए आप 2 ड्रग्स दे सकते हो प्रिवेंशन के लिए, ऑक्सीटोसिन साइमल्टेनियसली मीजोप्रोस्ट. अदरवाइज पहले कहते थे ना लोग कि zycloprost वगैरह, तो these two drugs are there for two
Yes,
drugs, two manuals. इसमें थोड़ा थोड़ा ऐसे याद कर करके ना बहुत अच्छा है. PPH is one thing. अगर सब इसमें पूरी टीम तैयार होगी, कहीं कोई कंफ्यूजन नहीं होगा.
जी मैडम, जी मैडम, बहुत ही अच्छा. और इसको हम
अच्छा,
चाहेंगे
Anita,
मैडम कि अधिक से
Anita,
अधिक
are you
फैसिलिटी
there?
देते
Anita is always there. Anita
Yeah.
and Dr. Abba Singh, who is मतलब this. Please see, Kavita, is there a few people from your side? Ask them to say few words. Hi, Anita.
हेलो
Good
मैम.
evening, मैडम, नमस्ते.
हेलो हेलो, गुड इवनिंग.
नमस्ते सखी.
नमस्कार कविता जी, बहुत सुंदर तरीके से आपने प्रस्तुत किया है इसका. वंडरफुली
Thank you, madam.
एक्सप्लेन्ड एंड इट वाज लाइक अ ड्रिल गोइंग ऑन. It was
Yes,
just
madam.
coming in front of our eyes, and you have covered each and every slide very nicely, explaining each
Thank
and
you.
every fact.
I mean, we
And
request you to come up to up next one. Like,
मैडम जस्ट हम एक
बड़ा
चीज
बोलिए.
बताना चाहेंगे जो मैंने एक्चुअली आई एम आल्सो लिविंग इन वेरी स्मॉल टाउन. दिस इज क्लॉट्स जो कई बार आते हैं ना, आई हैव सीन सक्शन से ना बड़े अच्छे से आ जाते हैं, उसके बाद मसाजिंग करने से एकदम से पीपीएस कंट्रोल हो जाता है. सो आई थिंक आपने लिखा रिमूव द क्लॉट्स मैनुअली, बट आई थिंक अगर क्योंकि सक्शन छोटा सा apparatus है मैडम, वेरी वन है, तो अगर उसको हम लोग कहीं से कर सकते हैं या
This is
बोल भी
very
सकते हैं
nice.
बिकॉज
हम
इट्स
लोगों ने पीपीटी में उसको ऐड नहीं किया है
कोई बात नहीं
कविता
मैडम,
जी.
ठीक है मैडम, इट्स ऑल राइट. लेकिन
अभी वो गाइडलाइन,
हाँ,
अभी वो
कोई बात नहीं
गाइडलाइन
मैडम, लेकिन एटलीस्ट शुड बी अवेयर, जानना चाहिए. क्योंकि मैंने मेरा अपना पर्सनल है कि उतना हैंड से नहीं रिमूव होता, आप सक्शन करो फटाफट से निकल जाता है और उसके बाद मसाज करो.
so many gynecologists are using suction और बस मतलब I think sooner or later, very soon it will be included in guidelines also. Then it will be very easy to us because ये बहुत अच्छा है. Everybody is saying or easy to use and not very expensive one also.
Yeah, exactly. Every
Kavita
facility
is
has suction
correct.
machine.
Yes, Kavita is correct. I remember a patient. We had to open her again after cesarean because her uterus was full of blood clots and was
Yes,
not coming because it was an elective CS and
yes,
the OS was closed. So they could not do even digital evacuation, and uterus is
yeah.
large for immediate postpartum first day. She kept on
Mm.
bleeding. The uterine size increased. As you have very well highlighted, if the
Yes,
uterus size
madam.
is increasing, be aware that the patient is losing blood inside, and patient's vitals started deteriorating. We had to open her head, open her up, and it was surprising that the bag, it was uterus was like a bag full of clots.
Yes,
And
madam.
as soon as we removed it, the
Hmm.
uterus contracted. The patient
Yes.
was all right.
Hmm.
Fortunately, we could save the patient because she diagnosed it promptly SR, and we immediately opened. I said, take no time, open her up immediately. Of course, the
Yes.
suction apparatus was suction cannula. That PPS suction cannula was not available. It would
Hmm.
have been a very great option if it was there with us.
Madam, in fact,
Definitely.
this is my personal experience, what I share. क्योंकि कितनी बार why clots were not coming, but when we applied suction, PPS suction cannula, all the clots come, and then when massaging was done, bimanual compression was contracted well. So I think this
उसमें
is
वो भी है ना कि ऑस क्लोज है तो फिर थोड़ा प्रॉब्लम की बात है, अदरवाइज तो
हाँ
दैट वाज वन
मैडम,
केस.
ऑस तो उतना तो ओपन रहेगा ही ना कि कम से कम वो पाइप चला जाए, कैनुला चला जाए.
बिल्कुल इतना तो ओपन होना
Those were the
चाहिए.
days. Those were the days जब anatomisoprost available था ना, ultrasound इतनी quickly करते थे. Because when you see the BP going down, if you see just 2 सेकंड में, आजकल तो टाइम नहीं लगता अगर आप टाइमली देखो. स्पेशली अल्ट्रासाउंड अगर आप ऐसे सेटअप में हो जहाँ अल्ट्रासाउंड आ सकता है तो आप जल्दी डायग्नोज कर पाते हो. और प्लस टाइमली वो ना सिंटोसिनोन ड्रिप एंड all those uterotonics should not be tapered off immediately. They should be going on. पर ऐसे में even at this time मेथडजीन वगैरह it is advisable, third choice, second choice also, because majority मैंने ये देखा है सिजेरियन करके अगर चले गए कंसल्टेंट, और सिजेरियन अगर इवनिंग में हुआ या रात में हुआ है तो थोड़ा सा ज्यादा इशू आता है, और नेक्स्ट डे जब आप देखते हो कि उसने कुछ नहीं पास किया तब तो पता लगता है.
Golden 2 hours, ma'am, Archana ma'am, golden 2 hours are very, very important.
Yes,
Vital
madam.
monitoring, keeping hand on patient's pulse. So residents must be, your pulse will tell you so
yes,
many
yes.
things.
ये अपनी देखो, एक कंसल्टेंट को जितना मैक्सिमम हो सकता है पूछते भी तो 1+, जितना उस पर ध्यान रखेंगे ना. 2 hours क्या, मतलब क्लॉट्स वाले में तो आफ्टर 8 hours ही पता लगेगा मे बी, बट इट इज गुड. General care, post-operative care is so important, and cause for the elective cesarean is also choose patient wisely. That is
हम
also
तो
very, very
भेजते ही
important.
मैम लेबर रूम कॉम्प्लेक्स से बाहर ही नहीं भेजते 2 घंटे से पहले, दोबारा से एक बार अच्छे से देखेंगे, एक
हाँ
एसआर कंफर्म करेगा एवरीथिंग इज फाइन, ओनली देन पेशेंट इज शिफ्टेड
But
आउट टू
even
वार्ड.
in a high risk patient, when I was PG, so once asked what are the causes of high risk patient, and I said elective cesarean, and really that doctor from she was from AIMS, and she was very, very happy. बोले she said
बिल्कुल मैम.
कि wow, it is something elective cesarean is not so easy कि किसी भी टाइम बैठे प्लान कर लिया और कर दिया. इलेक्टिव cesarean में आपको और ज्यादा ध्यान देना होता है, like previous
yes, yes,
or
madam.
previous LACS. Yeah.
Dr. Arpita Gandhi di has joined. Arpita di,
Dr.
आप
Arpita,
आप दीजिए
Thank
प्रेसिडेंट.
you, Kavita. बहुत informative your paper was, but I joined 20 minutes late. So I will request you to share the slide with me. And one my practical experience you told about slow trickle that is paraurethral tear.
Yes,
These are
madam.
usually
Just
missed because these are hidden under the labia minora near the clitoris, and at times it spurts also. And in our part, the patients are already anemic. For them, if this slow trickle goes on, it really at times after 4 hours or 5 hours, patient go into shock. And I was trapped in a case who was RH negative. So it was very difficult, but I managed because our professor, Sahu sir, you know it very well. You
yes, yes,
also
madam.
worked
Yes.
under him. He always used to tell कि paraurethral tear जरूर देख
हाँ,
लीजिए.
बहुत paraurethral tear. I have mentioned this sometimes small suburethral paraurethral tear, and that we usually miss. We see the cervix with the speculum, everything, but paraurethral tear is missed. So that we have to see. Sometimes this small oozing will continue and patient will go into shock. So this is very important to examine. Many times proper light, एक बार देखो, 2 बार देखो, ऐसा होता है मैडम. और उसके बाद फिर देखो तो पता चला कि एक छोटा सा लेसरेशन आ गया, वो ब्लीड कर रहा है. So
Even missing apex of episiotomy. Residents are doing this mistake so often. Missing the apex, they should be taught that the vessels will retract near apex.
और
So you
मैडम
have to
सर्वाइकल
go
टीयर
beyond.
स्पेशली लॉन्ग, मतलब जो हाई अप सर्वाइकल टीयर है उसकी स्टिचिंग प्रॉपर होनी चाहिए, पीजी को बताना चाहिए. क्योंकि क्या होता है ना कि हाँ भाई जो आपने बोला रिट्रैक्ट किया, तो एटलीस्ट जहां तक आप पहुंचो इसको लो, एंड देन यू पुल इट
Go
विद
up.
आर्टिक फोर्सेप्स एंड गो बियॉन्ड इट, एंड देन यू
बिल्कुल.
टेक द बाइट.
ये छोटी छोटी चीजें ही कई बार मैटर करती हैं. पेशेंट
जी
जैसे
मैडम.
मैम ने बहुत अच्छा बताया, गांधी मैम ने, कि
हाँ.
ट्रिकल करता रहता है एंड इट बिकम्स टोटल क्यूमुलेटिव लॉस इज क्वाइट अ लॉट. So patient can lose lot of blood for that matter. So the one has to be careful. Yes.
Yes.
Good evening, Archana madam.
मैडम आप नहीं ना आई देवघर पूजा के लिए. देवघर हम बुला रहे थे मैडम. अर्पिता जी वही की है प्रेसिडेंट. अच्छा मैडम कितनी दफा बना, इस बार आ
अर्चना
जाइए
मैडम को
सितंबर में.
आना होगा. एओजी एसबीजे में आना होगा. अभी हम ग्रुप
सितंबर में आ
में
जाइएगा
डाल
मैडम.
देंगे.
देवघर डायरेक्ट फ्लाइट है दिल्ली से. अनीता रजोरिया मैडम को बुलाई, तरुछा मैडम बुलाई. तरुछा मैडम के साथ हम लोग लंदन में थे ना मैडम.
सबको इस ग्रुप में
हमारा
सबको
डांस
आना
ग्रुप
है.
था.
धन्यवाद मैडम. जरूर आएंगे आपसे मिलने
आना
मैम.
है
थैंक यू.
क्योंकि इसका
Yes, ma'am.
स्लोगन है एक सम्मेलन 3 उपहार, पूजा
वाह.
पढ़ाई परिभ्रमण अपार.
क्या बात मैम.
वाह.
बहुत
फिर
सुंदर.
से बोलिए मैम, फिर से बोलिए.
एक सम्मेलन लाइक वन कॉन्फ्रेंस, बट यू आर गेटिंग 3 थिंग्स. 3 उपहार, पूजा पढ़ाई परिभ्रमण अपार. यहाँ बैद्यनाथ धाम है जो
घूमना
कि
भी है.
द्वादश ज्योतिर्लिंग में है, और एक बासुकीनाथ भी है. आप लोग को सबको हम अपने तहे
पास में है
दिल
मैडम
से
दोनों.
स्वागत
अर्चना वर्मा
करेंगे.
मैडम का 2 बार 3 बार हमारा प्लान बना, हर बार. अब इस बार आ जाइएगा मैडम सितंबर में. अभी अर्पिता दी है.
सिर्फ किसी के साथ नहीं हुआ होगा कि होटल भी हो गया, टिकट भी हो गया, सब कुछ हो गया, गाड़ी टैक्सी और टॉक भी, की नोट एड्रेस भी. उसके बावजूद भी देखो देव बाबा जब बुलाते हैं मुझे लग रहा है तभी पहुंच पाते हैं.
जी मैडम. यस यस. ठीक है. लेकिन इस बार अर्पिता दी भी बुला रही है, हम भी बुला रहे हैं. 2 सोसाइटी के लोग बुला रहे हैं, इसलिए आपको आना है.
अरे बस अपनी बात है. कविता बस तुम्हारी जय हो.
एकदम आना.
अर्पिता मैडम देखो, आप तो आपका नाम ही बड़ा है. मुझे आई मस्ट से AR मेरे को यही लगता है. आर गांधी है ना. बस आप बताओ सबसे टॉप का ही नाम है.
और आपका जो वो इंदौर वाला टॉक था मैडम, वो हम जीवन में कभी नहीं भूलेंगे, बहुत अच्छा टॉक था। और उसमें उस समय वो अर्चना शर्मा वो कर ली थी, उस पर आपने
हाँ,
इतने
कोटा में।
अच्छे बोला था ना कि रो दिए थे हम,
मुझे
बहुत
याद
अच्छा
है,
अच्छा लगा था।
मुझे
सही
याद है
में
वो।
मैंने दो
मतलब उस
डेथ
टाइम
हो गया मैडम, इस वेरी
हम्म,
मतलब टचिंग, इतना कि
एक्चुअली
एक
मैं
पर्सन
बहुत
से।
बहुत दिनों से पीपीएच पे ही बोलती हूँ। उस टाइम एकदम से ऐसा हुआ था तो मुझे इट वाज सो क्लोज टू माय हार्ट कि भाई आप अपने दिल पे मत लो भाई, काम सीख लो, टीम को बुलाओ किसी भी तरीके से लाइफ में
और
कभी
क्या
भी।
मैडम, यहाँ
आपको
पर
कोई
ईगो।
कितना ही नेगेटिव बोल रहा हो, कितना ही नेगेटिव बोल रहा हो, आप लाइक माइंडेड लोगों से ही बात करो, और थोड़ा कोई सीनियर और गुरु टाइप का हो ना, जिससे आप जैसे पता मैडम से ही कोई बात कर ले भाई जल्दी से, पर एकदम से सेल्फ ऐसे अचानक इतने बड़े बड़े डिसीजन लेने का क्या फायदा हो रहा है?
बिल्कुल।
कुछ तो सोचो दूसरे के
अब
लिए,
मैडम
मतलब
वही
कुछ।
तो, अब प्राइमरी भी है लेकिन हिस्टेक्टमी अगर जरूरत है तो हम करेंगे, आपको पेशेंट को बचाना है, सेकंड अडॉप्ट बेबी बाद में हो सकता है। आपको पता है मैडम, एक हम रियल चीज बता रहे हैं, डॉक्टर शांतिराम मैडम का आप लोग नाम सुने, आई वाज पीजी एट दैट टाइम इन पीएमसीएच। उनके यहाँ पेशेंट, एक डॉक्टर खुद ही के थे अपने फैमिली में, और उनकी बहू थी, फर्स्ट बेबी, एपीएच, और उसका मतलब कैसे भी हुआ, बेबी आउट हुआ, सी डेवलप पीपीएच,
इवन कर
बस
देना
इतना
सही
क्रिटिकल।
थी।
हाँ, फिर हिस्टेक्टमी मैडम ने कर दिया, फिर मैडम पर केस उस हुआ, फिर मैडम ने नियर मिस करके एक टॉपिक बनाया था और वर्ल्ड कांग्रेस कलकत्ता में प्रेजेंट किया था कि वी आर जस्ट लाइक मैंने कि हम लोग नियर मिस की तरह है कि भाई कब हम ट्रेन पकड़ लिए, कब छोड़ दिए, कब मदर को बचा लिए, कब मिस कर गए। फिर मैडम को केस हुआ लेकिन अल्टीमेटली सी वोन, क्योंकि भाई सेविंग मदर इज मोर इम्पोर्टेंट, यूट्रस बचाने से ज्यादा जरूरी है माँ को बचाना। अब मैडम बहुत जगह इंटरनल कार्टिलाइजेशन नहीं जाते।
टाइम थॉट ब्लॉक जो आता है ना सबको, वो दूसरे फ्रेंड्स ही बचा पाएंगे, जैसे आपको नहीं लग रहा है। आप
जी
जैसे मान लो मुझे कुछ सोचना है, इसी आज ही बोलना है कविता की तारीफ में, मुझे कुछ नहीं बोला जा रहा तो मैं जल्दी से फटाफट बीच में बोलूंगी तरु जी आप कुछ बोलिए, तो जब तक तरु कुछ बोलेंगे मुझे हो सकता है कोई नया सेंटेंस अच्छा सा और याद याद आ
जी
जाए।
हाँ जी।
तो इट इज ऑलवेज गुड कि हाँ भाई एक के बाद एक, जब आप मौका दोगे ना तो भगवान भी मौका देता है फिर सबको,
जी मैम।
ये साथ मिलके ही काम होता है।
जी।
It can
चलो
happen with
ठीक है,
anyone, ma'am. In Aligarh, my cousin Bhabhi was being operated for primary twin pregnancy. She landed into a tonic PPH. They gave each and everything, everything was done, but bleeding will not stop. My chachi is calling me, beta, they are going for ops hysterectomy. What should I give the consent? Man, don't think even about it. Give immediately. You're going to lose your this thing. The mother will go within minutes. Every second counts. So they did hysterectomy, but she could. The obstetrician could save my bhabhi. So it's all right. It happens so, but you have to sometimes sacrifice
It is
uterus to
called
save
luck.
the
It is called sheer luck. In my
mother.
PG, I remember one case, and throughout my life, I will remember newly married from a royal family, Nawabon की family से आई थी. She was in shock. Very second day of her marriage, or a huge vaginal tear going through
My
and
God.
through and through and through. एंड वो रात में उन लोगों ने शर्म से बोला नहीं, कुछ बोला नहीं, और उसको पता नहीं 12 बॉटल ब्लड चढ़ी, और इट वाज
My
रियली
God.
एक्यूट। उसके बाद वो रीनल फेलियर में भी चली गई, सब कुछ,
हाँ,
बट अल्टीमेटली वी कुड सेव हर।
great, great.
ये भी ऐसे भी हो सकता है ना मैडम।
ये भगवान का आशीर्वाद है।
हाँ
मरीज टाइम से पहुंच गया, ये भी बहुत बड़ी बात है
हाँ,
मैडम।
इतना भी
सही
हो
बात
गया, इतना भी हो
हाँ।
गया, मतलब सोचो कि उस लेकिन अदरवाइज जाकर ना पहुंचने, प्रॉपर फैसिलिटी पे पहुंचना ही मुश्किल है, सारी
मुश्किल
स्टोरी
होता
वहां
है,
पर भी है।
एग्जैक्टली वही होता है।
चलो ओके, थैंक यू वेरी मच, टुडे
थैंक
इज
यू सो
ग्रेट
मच
डे।
मैडम, थैंक यू फॉर गिविंग मी
थैंक यू सो मच
अपॉर्चुनिटी।
मैम।
बहुत
थैंक यू
मजा लगा कि
एवरीवन।
आपस में बात करें हम लोग, ऐसे ऐसा लग रहा है, बहुत अच्छा लगा।
थैंक यू
आज
सो
हमारी
मच।
मैडम नहीं मतलब आ पाई तो उनको उनकी ब्लेसिंग्स हम लोग थोड़ा मिस कर रहे हैं।
हाँ,
मैम बहुत अच्छा बोलती हैं, बहुत ही सबको बहुत मोटिवेट करती
नहीं हम
हैं,
सुने
इट
मैडम,
इज
और
हर
भी के
विजन।
बोले सुने हैं, बहुत अच्छा बोलती है मैडम। आई नो।
बहुत इनका विजन ही है।
Kavita is a great leader. She's a very silent worker. I really appreciate. Hats off
यस
to you,
यस
dear.
यस यस।
थैंक यू सो मच मैडम, थैंक यू फॉर योर वर्ड्स एंड ब्लेसिंग। मैडम मैं तो आपकी सखी हूँ ना, अनीता मैडम ऑलवेज सेज मी सखी।
Real good, real good. Thank you, Archana ma'am, for this
थैंक यू
opportunity.
थैंक यू अर्चना मैडम।
थैंक
आप
यू
इस बार
थैंक यू।
मैडम देवघर नहीं मिस करना।